Hello, my name is Naval. I'm a faculty in the Department of Leukemia at the MD Anderson Cancer Center in Houston, Texas. And today it's a pleasure to speak to you, giving you the ASH updates on the frontline AML treatment. As you all know, in AML, there's been a lot of progress in the last few years with many drugs approved, 10 drugs now FDA approved in the United States over the last 4 years. And with these agents, now there's a lot of shift in the current frontline treatment and progress in acute myeloid leukemia. So these drugs include targeted therapies, FLT3 inhibitors, IDH inhibitors, of course, venetoclax, which probably as a single agent has the most important impact in the treatment of frontline AML, and we're going to talk about that more. And now even oral formulations of hypomethylating agents, including CC486, that's approved as maintenance, as well as oral decitabine ASTX727 that's not approved in AML, but is approved in frontline MDS, and we think could become an important part of the AML treatment as well in the future. So this is kind of one of the treatment strategies or paradigms for newly diagnosed acute myeloid leukemia. As you see, we rely very heavily on molecular cytogenetic information to select the optimal frontline therapy. We still are selecting patients who are good candidates for intensive versus those in whom we think intensive chemotherapy could be difficult to tolerate, associated with high early mortality, severe infection, comorbidity. Although that boundary is shifting quite a bit. Historically, we used to say patients above 75 or very significant documented comorbidity where intensive chemo would be absolutely prohibitive. That's where we did HMA alone. But that was because HMA alone gave us only 25-30% response rate. So we really wanted to put most of the people onto the intensive chemo where the response rate was 75-80%. Now that pendulum is coming more towards a middle ground where with HMA-Ven and maybe even moving beyond with HMA-Ven combos, adding a third targeted or immune agent, we're now seeing equivalent response rate, 75-80% with intensive chemo with HMA-Ven. And so even for our patients above 70, but even above 65, in the United States at least, there's a shift towards using HMA-Ven-based therapy. And if the goal is to get to allotransplant, then you can get there pretty smoothly and with equivalent activity with intensive chemo HMA-Ven-based approaches. For patients below 65 and those between 60-65, there's always a decision depending on comorbidities, patient preferences, how far they live from the primary center, whether the goal is eventually transplant or not. And then now molecularly, we're identifying a group where really both intensive chemo, HMA, HMA-Ven are not really making much progress. These are the TP53 mutated AML. And for these, we really need to carve out unique targeted biological agents that will hopefully work there. Right now, the leads are with the CD47 drugs like magrolimab or APR, but there are others that are also being looked at in the preclinical and early phase 1 setting. So now talking about updates from ASH, I'm going to focus on the front line. It will become very overwhelming if we try to cover everything. Maybe in the future, if there's opportunity, we can talk about the relapse. There's some exciting things there, like the menin inhibitors coming. But in the front line, we'll look at intensive chemo and then the lower intensity combinations, doublets, as well as 3-drug combos. When you look at intensive chemo, I think there were 3 or 4 really important abstracts that may have impact in clinical practice and decision-making. So one of them here is the addition of CD33 antibody drug conjugate gemtuzumab to backbone intensive chemotherapy in the focus molecular group of NPM1 mutated AML. As many of you know, NPM1 mutated AML is a pretty big group. About 30-35% of younger patients below 65 will have an NPM1 mutated AML. We know that gemtuzumab historically has worked very well in patients with favorable cytogenetic abnormalities, such as the core binding factor inversion 16821. And there has been discussion and debate that in some series, it also seems to work well in NPM1 mutated AML. And so a lot of credit to the German group here for leading this effort. Hard to do this in molecular targeted groups because you obviously have to screen patients, get the molecular information, and then randomize them to the study, but they were successfully able to do this. And this was the design here. Patients would get therapy induction with the traditional idarubicin, etoposide, cytarabine approach, which is the one that is very commonly used in the German cooperative group. And here we added gemtuzumab. So you see gemtuzumab is added with induction 1, induction 2, and consolidation. So a total of 3 doses of gemtuzumab 3 per meter square, capped usually at 4.5 milligram, standard approach to using gemtuzumab that we at Anderson have also done with flag gemtuzumab, where we give gemtuzumab on 3 different courses of the flag. So same cumulative dose. And this has been well tolerated without much VOD toxicity. So these were the patient characteristics, very matched basically is what we see. Yes, many are de novo, that's expected. NPM1 is much more common in de novo. 90-95% of these people are de novo. And also many of them are favorable intermediate, again, because the selection was using NPM1, which we know usually falls either in favorable or intermediate if it has a co-occurring FLT3 ITD, which now is considered to be among intermediate ELN 2022. As seen, many of them did have a co-occurring FLT3 ITD, about 20% with ITD and 10% with TKD. A little lower than one would expect. Usually with NPM1, we see about 45-50% have concurrent FLT3. I think this may be because some of those who had a FLT3 ITD probably were triaged to FLT3 inhibitor clinical trials that are probably running, or with the approval of midostaurin, people were starting to get that for the FLT3. So you are seeing more NPM1 without FLT3 enriched here than you would see in a general frontline population So the key endpoints here were event-free overall survival. As you can see, there was a trend in the event-free survival with the more mature follow-up, with benefit for the addition of gemtuzumab to the idarubicin cytarabine etoposide, but overall survival was equivalent, no trend at all there towards any benefit. When we look at the subsets, it's interesting, patients who are younger, that is 18 to 60, for event-free survival, you do see a clear benefit. So if you look at the light blue line versus the bright green, these were the patients who were 18 to 60 who got gemtuzumab versus did not get gemtuzumab, and you can clearly see there's a difference there. P-value is also significant. However, in the older than 60, which are the 2 lines at the bottom overlapping each other, there was no difference. For overall survival, however, there was actually no difference both in below 60 and above 60 years of age. So I think it's interesting that there may be some benefit towards improving the remission duration and avoiding relapse, but maybe even in the salvage, we are able to successfully get NPM1 back into remission, and that's why the overall survival was not as impacted. Now, looking at different molecular subsets, what we see is that in the FLT3 ITD negative, which again, remember, was about 65-70% in this specific study. So they were NPM1 mutated, FLT3 ITD negative. There, the gemtuzumab seems to have more benefit. And again, I think what this indicates to me is that if you have a FLT3 mutation, the best bet is to go for a FLT3 inhibitor. Gemtuzumab is not going to sufficiently overcome that. Gemtuzumab may have some benefit in FLT3 that was shown previously by the alpha group, but the FLT3 inhibitors probably have more benefit. Now, could you combine them? That's actually being looked at. We, of course, have to be careful with myelosuppression toxicity, so I would wait for those trials. But for today, if there's a FLT3 mutation with or without an NPM1, my inclination would be to go with a FLT3 inhibitor, either midostaurin or more likely now quizartinib. I'll talk about that in a few minutes. If there's an isolated NPM1 without a FLT3, one may consider the addition of gemtuzumab, but the OS does not seem to suggest that there would be a great benefit. And then in DNMT3A mutated patients, the addition of gemtuzumab did have benefit. So all said and done, at this point, I don't think to us, at least at Anderson, it's going to change our practice, or in the US and large academic groups. I don't think we're going to be adding gemtuzumab to NPM1 mutated. If they're FLT3 mutated, regardless of their NPM1 status, we're going to go for a FLT3 inhibitor with induction chemotherapy approach. And I personally think that this may be a group where drug combinations such as FLAG-IDA venetoclax or 3+7 venetoclax may be the way to go. Data that I will show you and has been presented now from our group with both FLAG-IDA Cleaven suggests that in the NPM1 non-FLT3 mutated patients, the responses and survival are very, very good with that regimen. And we know VEN does work well in NPM1, whether it's with HMA or now we think even with intensive chemo. So I think at this point will not change our use of gemtuzumab beyond the frontline core binding factor inversion 16, 821, where we have continued to use it in the past with the FLAG-GEO, or others are using it with 3+7 GEO-based approach. What about FLT3? Since we talked about NPM1, I think there's a lot more happening and a lot more potential changes to practice that will come in FLT3 in the next 4 to 5 years, starting potentially with the incorporation and hopefully soon approval of FLT3 inhibitor quizartinib in the frontline FLT3 mutated acute myeloid leukemia. So you all are hopefully aware, or if not, I will mention that the Quantum First study, which was a very large multi-center phase 3 international study, randomized 450 patients 1:1 to get quizartinib with intensive chemotherapy versus intensive chemotherapy placebo in newly diagnosed frontline FLT3 ITD mutated AML, was completed. The primary data was presented at the EHA meeting by Dr. Harry Erba in 2022, and the study met the primary endpoint, which was overall survival with benefit for addition of quizartinib to the backbone of cytarabine with anthracycline. So that will hopefully get a frontline full approval for quizartinib. It's important to note, because the first question that comes to mind and has been discussed a lot in many different meetings and ad boards that I've been in is that how does this differentiate from midostaurin? So the study is quite different because, number one, this allowed patients 18 to 75 years of age, whereas the midostaurin study was 18 to 60. And when we look at the Quantum First, in fact, 40% of the patients on this study were above 60. So those would be patients who would not have been on the midostaurin. And of course, we know above 60 will have less favorable outcomes. So that, of course, has to be taken into account since almost half the patients here were older than those who would have been allowed and ratified. The second is that these are all ITD, whereas 25% of the patients on the Ratify study were TKD. And so it is also important to note, because ITD tends to be the one that carries the more significant proliferation and negative impact. So this is a harder population. We, of course, would like to see the data in below 60 and above 60 for those two studies, and hopefully that will be there in the primary publication that should come out hopefully sometime later this year. So this was the primary endpoint. As mentioned, this was met. These were 18 to 75 years of age. So in that population, to see a median of greater than 30 months and a 3-year survival of 50% is quite encouraging. Again, what I would really like to look at and discuss in more detail in the future when that data is publicly available is below 60 and above 60, because that, I think, is really the key decision maker. For above 60 and above 65, as I mentioned, we really are heavily moving towards HMA-VEN or HMA-VEN backbone with a third drug added. So I don't think that is where we are going to be focusing our attention with the intensive chemotherapy combinations. So here we now see the outcome in patients, based on whether they received the allogeneic transplant in CR1 or not. I think this is really important because a lot of times people ask that, well, if we are adding a FLT3 inhibitor, do we now need to continue to do transplant or not? The simple answer is absolutely yes. The best way to address FLT3 mutated AML is with a total therapy approach, something you who are treating myeloma are familiar with. So it's not going to be one intervention that we think can dramatically improve the cure rates. The FLT3 inhibitors add the benefit, they improve the response, they improve the depth of response, they get more people into a position where they could be effectively transplanted, but transplant still has a critical role. Here you see on the top two solid lines, the blue and the green solid lines, patients who had transplant with quizartinib on the top or with placebo. And so really with both, getting to transplant is important, but with the FLT3 inhibitor, getting to transplant is the best. That's where we're looking at 3-year survival of 75, 70%. So that's where we want our patients to be. So in our practice, we usually find the FLT3 mutation, rush the testing, add the FLT3 inhibitor, get transplant on board very early with the goal to move after 2 cycles or maximum 3 cycles in a remission to transplant. And then now, even beyond that, adding post-transplant maintenance with FLT3 inhibitor. I think with all of these approaches, and hopefully with the use of frontline second-generation FLT3 inhibitors like quizartinib, or potentially in the future when data comes out, gilteritinib, we may start seeing 70, 80% long-term survival, which would be fantastic because historically, this was a group where the 5-year survival was 20 to 25% just 20 years ago. So I think there's a lot happening, a lot of progress in FLT3, but transplant is still critical. Now, are there some patients where we could avoid transplant? So that is the question that we're trying to get at with this data and with other data sets. Maybe yes. I still would say in our practice, we're still leaning towards transplant in the broad majority, unless, of course, they're very frail or they have severe infection or they don't have a donor at all, which is an uncommon problem, but it could happen, or the patient really, really, really refuses transplant after all the discussion. But one could contemplate in those who are MRD negative who go to transplant, there does seem to be here the signal that if you're MRD negative, whether it was on quizartinib or placebo, and you go to transplant, there may not have been a clear benefit for transplant. Again, this is a subset analysis, not powered, so it's hard to say. But those who are MRD positive, it's very clear that transplant is really, really important. And here, the patients who went to transplant, especially with quizartinib-based therapy, could do well. So I think the point here is that in patients who are MRD positive, the FLT3 inhibitor was doing the best, and probably is one of the ways the FLT3 inhibitor helps in the long run. Those who are MRD negative, transplant itself, I think, is important. The question is, maybe we're able to reduce the duration of post-transplant maintenance, or maybe over time we will be able to avoid transplant, but I think we're not there yet at this point. So the next question is, what about moving beyond the traditional 3+7? This is something that we at MD Anderson have been working on for the last 7-8 years, and have been passionate about the regimens of FLAG-IDA CLIA, many European nations also using similar regimens. But really the big change I think here is the incorporation of venetoclax. We know HMA venetoclax work well. We know FLT3 venetoclax can work well. And here we now are starting to see that intensive chemo venetoclax can also work quite effectively, but also causes significant myelosuppression. And so that has to be taken into account. And I think this is the regimen that really should be used in younger patients. And when we say younger, I would say below 60 is where I would consider this. And as you see in this study that Dr. Kadia from our group led, in the 67 patients, the median age was 48, and the majority, 90%, were below 60 years of age. Other than that, this is a kind of traditional, typical population you would see, where there's a population of patients who have adverse cytogenetics, about 20%, and the others, about 60 to 80%, are intermediate. So this is kind of what we see in younger than 60 newly diagnosed frontline AML in. And here the regimen used was CLIA, cladribine, idarubicin, cytarabine, so incorporation of the purine analog, as well as a higher dose of cytarabine, similar to what the British and Polish groups have published on. And the consolidation you see is the same 3 drugs, but at lower doses. And most importantly, venetoclax was added. But importantly, in this study, the venetoclax was only added for 7 days. So there's been this debate, and I'll show you some data that I think is very, very important about the optimal minimum duration of venetoclax that is needed to give the synergy and similar outcomes. And, we initially were doing 14 days of venetoclax with FLAG-IDA, but now with this 7-day venetoclax with CLIA showing very good responses and activity, we think 7 days is actually equally sufficient, less myelosuppressive, with less severe infection when you combine it with intensive chemotherapy. So that is the approach here, 7 days of venetoclax with the CLIA. Very difficult to argue with the response rate, 96%, that is great, with a true CR rate, full count recovery in 85%. So as many of you know, we have never seen this degree of true CR rate with frontline intensive chemo. It's usually in about 60, 65% for a true CR rate, but here 85% is looking very good. And then best MRD negativity was 90%. This is using the flow at MD Anderson, which has a sensitivity of about 0.01. So quite a good flow assay. And you see the early mortality, again, in experienced hands with selection of the younger patients who can tolerate this at MD Anderson, and a lot of support as needed with infectious disease, other supportive measures, this regimen can be delivered safely. But that is really key, that I would not try this in a community setting, or if you don't have a lot of experience with venetoclax or don't have good infectious disease, pulmonary, other support, because this regimen can cause myelosuppression infections. But of course, if you can do it, it could also be very fruitful and effective. This is just showing that responses were seen across the favorable, intermediate, adverse. Response rates were the same. It didn't seem to matter deployed or non-deployed. This population does have less TP53 and FLT3 than expected, and that's partly because of those patients being triaged to other clinical trials ongoing at Anderson at the same time. So for the TP53, as many of you know, we've been enrolling those patients onto CD47 APR studies. Even the younger patients are going on those because we know intensive chemo doesn't seem to do well. And for the FLT3, they're moving to FLT3 inhibitor incorporating studies such as FLAG-IDA, CLIA with gilteritinib. And that's why you see less of those. But everybody else is similar to what you would see in the general population. Overall survival is looking encouraging, but only 2-year median follow-up. So we will wait for the 3 and 4 year. But if you overlap this curve with what we have seen in the past with CLIA, FLAG-IDA 3+7, then this actually does look better than what would be expected. So we think this is looking like a good regimen. Here again, transplant still remains critical. So we are not getting away from transplant. If anything, we're finding ways to get people into a deeper remission smoothly to transplant, then allowing the transplant to come in and help improve long-term cure rate. So with transplant, as you can see, this is looking very good, 80% now at 2 to 3 years. Without transplant, not bad, but coming down to close to 45, 50% at the 2.5, 3 year mark. So still, we would push for transplant if we can in these patients. The transplant rate in this study is pretty high, almost 75, 80%, as you can see. What about count recovery? This is something people are very concerned about, and we should be, because venetoclax incorporation is potent and synergistic, but also adds myelosuppression across every combination where venetoclax has been added. The good thing is with the 7 days of venetoclax and with the optimized dosing, cytarabine is 1,500 here, not 2 grams, unlike the prior historical FLAG-IDA. With those changes, we're actually seeing pretty good count recovery between 24 to 35 days for ANC and platelet, which is very acceptable. But again, this is with the... So what about the other regimens with venetoclax? FLAG-IDA, as you know, has been done by our group. Dr. Donardo and colleagues have presented and published on that. And the Italian cooperative group here, led by Dr. Martinelli, Marconi, and others, took this approach and wanted to confirm whether they are able to deliver this regimen that MD Anderson has done in a larger cooperative setting across institutions in Italy, to confirm whether this is a usable regimen outside of ultra-large academic center. What they did was very similar to our regimen, with fludarabine for 5 days, same dose, idarubicin for 3 days, same dose, cytarabine. They actually did use 2 grams. We have been using the 1.5. And the venetoclax here, interestingly, was given for 14 days total, as I mentioned, although with discussions with the Italian group, they're thinking of dropping this down potentially to 7 days as well, as we are doing on CLIA, because the CLIA-VEN data looks quite good, and the additional 7 days may not be adding much other than myelosuppression and infection. Again, here, young population, majority are below 65, but again, I would even say below 60 is where I would use this. And you see that about 45% are ELN intermediate, or ELN high risk. And so here again, we see that the response rates are very good, whether it's the VEN 400 or 600, we're looking at a overall remission rate of 85% and a true CR rate, again, of 70 to 75%, depending on the dose used, with MRD negative in about 75, 80%. So looking very translatable from what we had seen with the MD Anderson, FLAG-IDA, venetoclax, CLIA venetoclax, and this was able to be delivered in multiple centers across the Italian cooperative group effort. Again, this is very early, so I don't know if we can put too much on it, but the OS is looking encouraging. We do need, I think, a 2-year follow-up at least to really see where those curves plateau. Anything above 50, 55% at 3 years, I think would be considered quite encouraging, given that historically with 3+7 or traditional backbones, we've seen about 30, 35% 3-year survival. So if we could get to above 50%, I think that would be a step in the right direction to start with. They also did a propensity matching, because this is not a randomized study, but to try to get an idea of their historical traditional 3+7 regimen versus now the FLAG-IDA-VEN. And what you can see is that the response rate is about 20% higher. The MRD rate is significantly improved from 48 to 74%. That's quite striking. And then the disease survival is trending favorably. So hopefully with another year or so follow-up, we will see if they continue to see this benefit in DFS and hopefully OS. But good confirmation of the FLAG-IDA venetoclax experience that we had tried here. So this is now looking at switching towards HMA-VEN. So in the beginning, I mentioned, where do we start using HMA-VEN? Is there an age cutoff? Is there a fitness cutoff? Is it molecularly selected? So the group at UPenn here looked at a real-world comparative analysis of 7+3 intensive chemo versus HMA-VEN in younger adults. So these were patients 60 to 75 years of age. So not fully young, but 60 to 75 years of age. These were patients who would not normally have gone in the VIALE. VIALE was 75 or above, or if they had a clear comorbidity. But the question was, what about those who are 60, 65, 70? And they were able to get a big data set, about 700 patients. They pooled data from both their UPenn experience as well as from the Flatiron database. And then you see the flowchart of the treatment regimens patients went through. About 300 got induction, about 400 got HMA-VEN. What they basically concluded is getting to transplant is what matters. And whether you get there with HMA-VEN or whether you get there with 7+3, when you look at the survival, the top two curves are those who got to transplant. So what really matters is getting the patient to transplant. Now, if you could do it with HMA-VEN, with less toxicity, less inpatient stay, less transfusion, less mucositis, less morbidity and mortality, I personally think that I would be leaning towards HMA-VEN. I really think I would like to see intensive chemo doing clearly better than HMA-VEN in patients who went to transplant to convince me to continue using intensive chemotherapy, because the HMA-VEN is a much better tolerated regimen. Yes, there's myelosuppression, but a lot of the other toxicities are not seen. So I think a lot of people using this data are saying, well, for my 65, 70-year-old, I may start considering HMA-VEN. We've already been doing that based on other data and experiences, but I think such analyses are helping to push us in that direction. They further did some statistical modeling to try to identify patients based on the selection of the investigators and try to reduce selection bias. What they found overall is that among patients, based on those who received HMA-VEN and 7+3, when you try to model it and try to avoid the selection bias using statistical modeling, it looked like these patients had very similar outcome. And so that is something that is useful. We'll have to wait for the full paper to read the details of how this modeling was done. The other question here is HMA-VEN sufficient? Are we done? Are we set? We should be happy. Let's go home, HMA-VEN. We don't need to keep pushing trials. And the answer is obviously no, which is why I'm showing this data. So this was a long-term follow-up of HMA-VEN. And again, really depends on how you like to look at it, glass half empty, glass half full. So as you all know, this is the VIALE-A study, 430 patients, landmark study. This was published in New England Journal a couple of years ago, azacitidine placebo versus azacitidine venetoclax. Primary endpoint overall survival, key secondary endpoint was CR and CR/CRi rate. And these were all de novo or secondary AML who had not received prior HMA, and prior MPN patients who transformed to AML were excluded from this study. And so here you see the long-term follow-up. And so glass half full, you can clearly see HMA-VEN is doing better than HMA. I don't think anybody would argue that. From the beginning, the curves are separated, whether it's the median or the 3-year point, you're doing better. 23% versus 7%. Was the long-term survival with HMA-VEN versus HMA. So that's good. But if you showed this to somebody who's not in the AML field, I think they're going to say, well, yeah, this is a good beginning, but obviously you are far from where you would like to be 10, 15 years from now for your patients. We would like this curve to be at 50, 60, 80%. So I think it gives us a good first step to improving outcomes in the elderly patient population, but I think there's much, much more that can be done. Now, MRD could help maybe select some of these patients in the future. Those who do achieve MRD negativity, less than 10 raised to minus 3 or 0.1 is the accepted MRD cutoff by the ELN and the FDA for calling patients MRD negative. And those who are MRD negative, you can clearly see that their 3-year survival is looking better, closer to 50%, as compared to those who were MRD positive, where the survival there is limited, with the median coming around 14, 15 months. And then when you look at it further, whether you look at the placebo or the AZA-VEN, what seems to matter is achieving MRD negative. So the orange and the green lines are those who achieve MRD negative. Of course, the rates of MRD negativity are much higher on the AZA-VEN, 69 versus 11 patients on those arms. But if you achieve MRD negative, even AZA can do well. But of course, with AZA-VEN, you have a much higher chance of achieving that. So maybe those who don't achieve MRD negative after 4 or 5 cycles is where we could consider intervention, whether it's adding a third drug or an immunotherapy approach. The point is, AZA-VEN is good, but the long-term survival is 23%. There's much more we need to do. The second big question is how much venetoclax, and it kind of links in my mind to the first question, because if we're going to move beyond AZA-VEN, the first thing I personally think you need to do is reduce the duration of VEN. There's no way you can add a third drug, even one with minimum myelosuppression, on top of a AZA-VEN 21 or 28 days. So this was a very commendable effort by the French group led by Dr. Botton and Christophe, where they said, okay, there's a lot of discussion and debate, and every meeting we go to, people say we use 14 days, and some are 21 days, and some are even saying 7 days. What is the minimum amount of VEN that you need to get a good response? And by using a minimum amount, could you open up space to add a third drug, whether it's a targeted therapy, FLT3, IDH1, IDH2, menin inhibitor, CD123, CD47, all of these. So this looked at a large number of patients, 7 centers in France. They were stratified by the ELN22. VEN and AZA both were given for 7 days, no treatment for 3 weeks after that. And then they looked at the outcomes and count recovery. So here what you see is that across the population of patients treated, overall, these were very similar to the VIALE-A. Majority were above 75, actually a little bit older even than the VIALE-A population, and about 30% had therapy-related AML, with 1/3 having a PS of 2 or higher. So this is a similar or even maybe a little bit more difficult population than the VIALE-A population. And also about 20% have TP53, and about 70% are ELN 2022 adverse risk, which is similar actually to the VIALE-A. When you use the ELN 2022, which remember was developed from intensive chemo, but when you use it in the HMA-VEN population, a majority of the older AML, in fact, do fall in the adverse risk population. So what was really striking here was the response rate, right? 7 days of VEN, not 28, not 21, and almost exactly the same response rate that's been published by the VIALE-A study 2 years ago, 68%. It was 69% in the VIALE-A. Median time to response is 2 cycles, a little bit slower maybe. It was 1 cycle with VIALE-A, but you know, given that we're using only 7 days of VEN with less myelosuppression, less toxicity, less neutropenic fever, very acceptable. And again, the NPM1 IDH2 well, so it is exactly the same as has been shown by Dr. Poli and others, 43% with the VEN 21 days. So adding VEN or lower VEN did not seem to matter here. So this to me is very critical, striking data that we may have been wrong in the amount or duration of VEN needed. 7 or 14 days may be similar. Most of our studies, we have moved to 7 days, CLIA-VEN, FLAG-IDA-VEN. In some of the combinations of HMA, we're going more towards 14 days, but one could argue maybe in the future, even 7 days is a way to go. Now, the OS is lower, 12.8 compared to about 15 months. So here one could argue maybe it's a little too low, the 7 days. We don't know. This was a little bit older, frailer population, more comorbidities, but at least to achieve a response, the 7 to 14 day may be sufficient. So that then leads to how can you then improve outcomes? So you may not need as much VEN. Giving 28 days of VEN does not seem to improve the outcome. So then what can we do? And so this is where addition of the third drug, something that we have been working extensively at MD Anderson, comes in, whether it's a targeted therapy, immunotherapy. Of course, the first ones are to look at the established targeted therapy like FLT3 inhibitor. So we pioneered the study of AZA-VEN gilteritinib presented by Dr. Short from our group. And here you again see we have started cutting down the VEN. This was, of course, before the data from Dr. Botanen group, but we already realized when we tried to give 21 days of VEN with HMA and GILT that the myelosuppression was prohibitive. So we had to go down to 14 days. But the way we did that is by doing a day 14 marrow, showing that there was clearance of disease. And in that setting, then it was safe to hold the venetoclax because there was no active or progressive leukemia. The FDA and our group were comfortable with that approach. What I will say is that almost everybody, and I'll show you the table, had a clearance of disease on day 14, which is not surprising because as was shown by the French group, the response rate was 70% for just HMA-ven 7 days. Now you're adding the gilteritinib and going up to 14 days. So in fact, almost all patients will clear their disease. And again, showing that you don't need to push 21, 28 days, especially if you're going to bring in a third effective combination partner, which will have its own activity included. So here the population is older patients, median age of 70, goes up to 86 years of age. A majority were above 60. I think there was one patient younger than 60 who had comorbidities and could not go on to intensive chemo, such as the CLIA-GILT or CLIA-QUIZ studies that we have ongoing, and the majority are ITD. As expected, of course, we know that 66 to 75% of FLT3 are ITD. There was a frontline and relapse, but I'm going to really focus on frontline because that, I think, is the eventual path for this three-drug combo. Again, here, hard to argue, 100% response rate in the frontline cohort, including a full true CR with count recovery 92%. A lot of people ask us, well, are these selected, et cetera? I will tell you in the last 2 years, pretty much every patient above 60 years of age, unless they're trained like patient ICU, intubated, having dialysis, other major issues, but almost every other patient, 90% we have enrolled on this as our frontline study, as we do for most of our frontline studies. So this is kind of representative of patients walking through the door with newly diagnosed FLT3. We do allow in our studies cytoreduction with cytarabine, Hydrea, other things, but they were all going on this study, and this seems to be a very good approach that we will continue to use. Early death, again, with experience, with the lower duration of venetoclax is not seen, but again, expertise comes into play. So then people say, okay, but the day 14, are you comfortable stopping on day 14? And the answer is yes. So when you look at the day 14 marrow in these 27 patients, you see that only 2 out of 27 actually had more than 5% blast. The other 25 all either became hypoplastic insufficient or had achieved at least significant debulking less than 5%, indicating that continuation of ven would probably have added myelosuppression with minimum or limited benefit. So I think we're very comfortable with this 14-day approach. We're still doing the 14-day marrow to get more information, but if we have 40, 50 patients where we can show that 14 days is really giving us response, clearance of disease in 95%, I think that can establish 14 days of ven with the gilteritinib as a good approach upfront. And so the 14 days is looking good for count recovery. Here you see recovery to ANC above 500, platelet above 50 is now close to 25, 35 days, which is acceptable and actually what's seen with HMA-ven doublet. So we had to slowly come down from 28 to 21 days of ven to 14 days of ven, and the GILT, we are coming down to 80 milligram. But now with this optimized three-drug regimen dosing, we are comfortable with the myelosuppression, low or zero early mortality, and good response rates. So there's a large study called the Viceroy study, which is a multi-center study across the United States that's going to be looking at aza-ven GILT in about 30 centers, again, to confirm, like was done by the Italians with the FLAG-IDA-ven, whether the experience seen at MD Anderson can be replicated in larger group, and whether this could be taken forward eventually as a approach. The OS, as you see, looks quite good. 1 year OS of 85% in FLT3 mutated older unfit. If you look at the Viale, the 1 year OS in FLT3 ITD was about 40-45%. So early, but the trend is looking favorable. Of course, this will be updated by next ASH. So we look forward to that. Interestingly, here we did look at transplant versus no transplant. Numbers are really small. I don't think we can make any conclusion, but it looks like here with and without transplant, the regimen is doing well. Maybe over 2-3 years as we follow up, we'll see a difference. I will say in our group, up to 70, 72, maybe even 75, if they're fit and they have a good donor, we definitely at least get a transplant consult and consider it. We'll continue to do that. If we start seeing over time that they do as well without transplant, then that will be a discussion once we have more mature data. But for now, we are considering transplant up to 72, 75 routinely for our patients. So now moving towards a more difficult group than even FLT3, the TP53 mutated population. Here, we really are looking very hard and trying everything we can, different combinations, maneuvers, novel drugs to improve outcome, because this remains the most difficult group in all of myeloid diseases, AML, MDS, with very poor outcomes. And of course, one of the key leads that has emerged is the CD47 pathway, and specifically in that pathway, a drug, magrolimab, which is the first in class, but there are many. There are 6 or 7 others being looked at, and we may find differences over time between them for both safety and efficacy. This is a ongoing investigator-initiated study at MD Anderson. We presented the updated data. The study is still ongoing. The total accrual will go up to 60 to 80 over time. And we're looking at both TP53 mutated and wild type. As you can see, this is a pretty difficult population because there is a selection for the high-risk patients to go on CD47. We are using this for our TP53 adverse cyto because for the FLT3 and IDH, we use aza-ven-girt or aza-ven-IDH inhibitor, and the remaining are usually the adverse cytogenetic and TP53. Other than that, very common age is 70 up to 84 years of age. You do see that the ELN risk is very high, going to 90 to 100%. These are all adverse risk patients, again, because of the self-selection for the CD47, the interest in that high-risk group, and then about 2/3 have adverse cytogenetics. So this is probably one of the highest risk populations you will see in a frontline study setting. Now, we're focusing on the patients who did not have prior HMA or MDS or MDS-MPN-directed therapy, and those are the de novo population of 33 patients. So what you see is in this frontline population, the overall response rate is about 72%. If you add MLFS, close to 80%, and the CR rate is 50%. Now, one may say, well, this is similar to HMA-VEN, and that's true. But again, remember, this is 90 to 100% ELN adverse risk, with 65% having adverse cytogenetics or TP53. So this is a very, very difficult and different population from the general VIALE-A. And actually, in our opinion, achieving these remission rates, CR rate of 50% and a MRD in 2/3 in such a population actually is quite encouraging and better than we would expect with HMA-VEN, where in the adverse group, the CR rate is about 25-30%, as has been shown for TP53 subset, and the MRD negativity is about 30%. Count recovery is good with this combination. Actually, we're seeing about 30-35 days, not different than HMA-VEN. And that was kind of anticipated, but it's good to show it clinically because magrolimab does not cause significant neutropenia and thrombocytopenia. It does cause anemia, and that, of course, has to be monitored, transfused in the first 7 to 10 days, but it does not seem to cause cumulative neutropenia and thrombocytopenia, which I think makes this a good, attractive approach for a combination. Here we see the early data. The follow-up is only 14 months, so we still need more follow-up to be fully confident, but with the TP53 mutated as well as TP53 wild type, when you look at the survival curve on the right, this is looking quite good. As you know, for TP53 mutated, median survival with HMA-VEN now in 3 published subset analysis is about 6 to 7 months. So here we are seeing at 1 year median has not been reached, but it's close. My anticipation is the median will be somewhere between 12 to 14 months, which is not a blockbuster. It's not going to cure TP53, but hopefully is the first step in the right direction. And then we have to find other drugs and optimization to further improve on that. The wild type numbers are small, but the survival curve is trending well and better than what we would expect with HMA-VEN. So we have to wait and see. Similar to what the Italians did, in the absence of a full randomized study data yet, we're looking at propensity analysis. So we tried to do as much apples to apples, frontline MD Anderson patients treated on HMA-VEN clinical trials in the last 5 years. And we then match those as far as possible for age, cytogenetics, therapy-related versus de novo to the aza-ven-magro. And what we find is once we do that match analysis for patients treated in our center in the frontline setting, there does appear to be a benefit with the addition of magrolimab. Of course, there's a randomized phase 3 study ongoing, the ENHANCE-3, that's going to look at this in a big population, 500 patients, aza-ven-magro versus aza-ven-placebo, which will include both the TP53 subset and a TP53 wild subset. And if it's positive, then of course could lead to a new frontline standard of care of HMA-VEN CD47, which would be nice to further improve that 23%, maybe to a higher level with the 3-drug combination. So these are the 2 phase 3s ongoing, aza-magro versus a investigator choice of either aza-ven or intensive chemo for TP53 mutated AML, and aza-ven-magro versus aza-ven-placebo for the VIALE-A population, older than 75 or unfit for intensive induction based on a documented comorbidity. And we're hoping to see data in the next 1 or 2 years with these studies. And especially for the TP53, I'm hoping this will be the first step forward, but we still need to keep working on the bench and preclinical, because even if this is positive, it's going to give you incremental benefit, not a blockbuster, and we still need more. Last couple of slides. There is another combination. We talked about FLT3, we talked about TP53 focused triplets for HMA-VEN. And now, what about those who don't have this FLT3 or IDH1 or 2 or TP53? So here the idea was to bring in a mutation non-selective or mutation agnostic therapy, such as a CD123 antibody. And this is an effort looking at HMA venetoclax with CD123 IMGN. This was initially done in the relapse population, as we do for most of our new combinations in phase ones. And overall, in the relapse, this was a safe combination. We did not see any severe cumulative myelosuppression. We did not see VOD. We did not see capillary leak syndrome or CRS. So it looks like a good CD123 drug to add to HMA-VEN. Response rates were pretty encouraging, about 50% overall, 30% CR, and especially in prior VEN naive, we see a CR rate of close to 50%. But I think it's very hard to compare these things in the salvage setting. So of course, what we need to do is move it frontline. And this study now is open across about 40, 45 sites in the US and in Europe. And very early data, but we hope to update this later at the ASH in 2023. And in the frontline setting, if we're able to get CR rate close to 50% and a CR/CRI of 80 to 90%, I think that would be the first good signal with the maintained tolerability, no increase in the 30 to 60-day mortality. But eventually, we're going to need to see duration of response, overall survival, to be convinced that this could be better than HMA-VEN. So we have to wait for the data. So I'm going to stop over there. A lot of frontline information that we had covered. And I have some questions here, so I'm going to try to go through those quickly since Dr. Moti couldn't make it. He's at the TCT, so I'm just going to moderate myself. So if a patient with a FLT3 mutation becomes MRD negative after induction with a FLT3 inhibitor, should allotransplant be performed or should the inhibitor be continued? Allotransplant should be performed. I don't think we're ready to make a leap of faith until we see really clear data, and ideally a randomized study, even a randomized phase 2, that actually takes people who are MRD negative and then goes to transplant versus no transplant continuation of FLT3 inhibitor. Until such data, I personally would go to transplant, and I would do a post-transplant FLT3 inhibitor. So again, the total therapy where you do both, you do the transplant and you do the post-transplant FLT3 inhibitor is what we're doing. Now we'll see in time, if there is randomized data that can show that not using transplant in a deep MRD negative situation is a good option. And again, when you talk about MRD, it gets, it could be a separate lecture and discussion, because what are we talking about? If we're talking about FLT3 with a high sensitivity PCR, like in vivo scribe 10 raised to -5 or negative, sure, maybe in that setting, you don't need to do transplant. Again, I'm nervous because we know that FLT3 is only one of many clones in AML. There could be other clones that could escape. So in our group for today, for patients below 75, newly diagnosed FLT3, regardless of allelic burden, adding FLT3 inhibitor, going to transplant after 2-3 cycles in remission, and post-transplant maintenance is the blanket approach. But as data comes out, hopefully in the future, we will see if that can be tailored. Share information about the optimal period of FLT3 inhibitor therapy in post-transplant period. Does it depend on MRD status? Fantastic question. Answer is, I don't know. We don't have the data. There is a study that I think will hopefully answer this conclusively. It's called the Morpho study led by Mark Levis. It's completed enrollment, and we expect in the next 6 months, hopefully there will be a data readout. This is looking at patients who had a FLT3 mutated AML who went to transplant and post-transplant were randomized to gilteritinib maintenance or placebo. Big study, 420 patients randomized 1:1. And my understanding is we do have on that study the information on MRD status pre-transplant, post-transplant, and every 3 months on study using high sensitivity 10 raised to -5 FLT3 in vivo scribe assay. So that will hopefully answer the question. In those who were pre-transplant MRD negative, number one, did the FLT3 inhibitor maintenance help? We may see it doesn't. You go to transplant with less than 10 raised to -5, and maybe the outcome was similar in those who got placebo gilteritinib. Number two, if it did help, did it matter if they got 6 months, 1 year, 2 years? We will find out. And then more importantly, what about those who are maybe MRD low-level positive pre-transplant, become MRD negative post-transplant? And then how long do you need with the FLT3 inhibitor? So a lot of information that we need to glean as this study becomes available. But for today, the simple answer I would give is we're going for 2 years. Why? because that's what we've done with other TKIs, with ponatinib, imatinib, dasatinib, etc. So that's kind of been the general number we have used. One can argue it both ways, but that's what we do. What I will tell you is many of my patients, when they come back and see us every 3 months in that post-transplant period and they get to 2 years, and I've had about a dozen of those in the last year to 15, especially those who are young, below 70. When I say, we can stop maintenance at 2 years, they will say, okay, well, what's the data? Is it going to have no benefit doing maintenance now? I said, well, we don't know. We have seen late relapses with FLT3. We've seen it with other TKIs like BCR-ABL. And so there's a possibility. So many of the patients will like, well, I'm doing really well, doctor. I'm working or going to college or doing 100% whatever I want to do. Yeah, I take a pill once a day. I might as well just continue it. If insurance allows us to do that, I usually will just continue it. So we at this time don't have an answer, but the argument I get that patients are pushing is not what we're seeing. In the initial period, they do, but once they're 2 years post-transplant, 3 years post-transplant in remission, doing their normal life, to take a pill for a while to reduce the small risk of relapse, most of them say, I'm just going to continue this to you. And I know that I did it possible without any risk of having it. So your experience, the optimal treatment regimen for patients with de novo AML with a complex karyotype. That's a great question. So that, again, could be a kind of a debate or a paper on its own. So when we say complex karyotype, there are a lot of things that go into it. What is a TP53 mutation status? Is chromosome 17 involved? Is there MLL rearrangement in that complex phenotype? So it's hard to give a broad answer, but I'm going to assume this is a complex karyotype with a TP53 mutated traditional high-risk patient. In that patient, if I had a trial regimen, 100% we're putting them on trial, whether it's AZA-Magro, AZA-Ven-Magro, we have AZA-TTI, we have AZA-ALX, we have all the CD47s, we try those. If I can't get them on CD47, I will still try a novel agent trial, AZA-Ven, CD123, whatever other options may be available, cladribine, low-dose Ara-C-Ven. There's no regimen, obviously, that has shown clear blazing activity. Otherwise, it would have been approved and become the NCCN standard. I'm hoping, and we're hoping, that the CD47s will show in the randomized setting that improves survival. I do not think it's going to cure a huge chunk of people, but it may improve the median survival from 8 months to 12, 13 months. That's a good first step. But the answer is clinical trial, absolutely, if possible. I will say we are not using, or very, very, very limited using, intensive chemotherapy in patients with complex karyotype with TP53. So especially those who have what we would call a multi-hit, I don't say biallelic, because the only way to know that really if you have chromosome mapping, which we don't normally in clinical practice, but if they have a multi-hit TP53, meaning 2 or more TP53 mutations, or a chromosome 17 deletion with a TP53 mutation, or TP53 VAF greater than 50%. If they have one of those features, we are not using intensive chemo. Even in a 30, 40-year-old, we are putting them on the trials with HMA-Ven-Magro, data showing the response and survival with those patients is equally poor with intensive chemo, HMA-Ven, 6 to 8 months. And so we really are trying to move to something different biology and effect. So we don't use intensive chemo, but anything other than clinical trial, HMA-Ven, one could even argue HMA alone, if it's TP53 is reasonable, because the difference in HMA alone, 6 to 8 months survival. So you could do HMA alone, like a DAC 10-day or AZA 7-day, or you could do HMA-Ven, but really try to get that patient onto trial if you can. That is really what I would strongly suggest. What is your opinion on the possibility of reducing the period of taking venetoclax treatment in patients? This is one actually. So a lot of people ask, what is the theme of ASH? The theme of ASH to me is less is more, and specifically for venetoclax. So I think there's now a huge amount of data that we really should not give anybody 28 days of venetoclax. I know from the label and other aspects that sounds maybe not optimal, but that is the reality. And we at Anderson, and I know most experts across the country who use a lot of HMA-Ven, are routinely now doing 21 days for the doublet. And if we're adding a third drug, which obviously based on the data and ongoing studies is becoming more and more frequent, we're really moving down towards 14 days but often doing a day 14 bone marrow. So the simple answer I would give is if you're doing HMA-VEN 21 days for the first cycle, do a marrow day 21 to 28. Once you've shown that there's less than 5% blast or hypoplastic insufficient marrow, hold the venetoclax, give the patient 2 to 3 weeks then to recover, check blood count 2 to 3 times a week during that period, but let them recover ANC above 1, platelets above 50, 60. For cycle 2, drop the venetoclax to 14 days. And then you watch your patient and decide after 2 or 3 cycles, if he's still taking 40, 45, 50 days to recover ANC above 0.51, then you drop the ven further to 10 or 7 days. So that's kind of what we've done. I would say by cycle 5 or 6, most of our patients who are on the HMA-VEN doublet are down to 7 to 10 days, about 80% of them. And that's really when it becomes smooth, their counts recover, they tolerate well. So start 21, go down 14, go down quickly if you need 7 to 10. Of course, all along checking blood counts, bone marrows every 2 to 3 months in that initial period. And I think good response and not push the toxicity or the risk. What about infection rates, specifically fungal? I guess it depends on the regimen. There are different regimens with different infection rates. With the flag-eyed event, Clear-Ven, actually we use prophylactic antifungals, posaconazole, voriconazole, Cresemba, and we have seen a limited breakthrough fungal infections. We do see it. It's more common in the relapse or in patients who have had multiple 4, 5, 6 cycles of these intensive chemo regimens. With the HMA-VEN, we don't see it actually that much, again, because we're dropping the ven quickly and allowing for neutrophil recovery to happen earlier. But our recommendation, and again, it may be regional, we're in Texas, I know in Miami, I know some of the City of Hope, some of these areas in the South where there's probably more endemic fungal, more heat, more humidity, we're using prophylactic antifungal. I have colleagues in the Northwest and Northeast where they may not have the same experience and see as much fungal infection, and they argue for using limited or using 1 or 2 cycles during neutropenia antifungal prophylaxis. Tailored to your practice, experience, and region. I don't think there's what is your maintenance strategy after achieving complete remission with AZA-VEN therapy? As I mentioned, reducing VEN quickly to optimize count recovery is basically our strategy. We do AZA-VEN continuously. We do not recommend stopping AZA-VEN. I am increasing the duration between cycles. So once somebody's getting to 10 to 12 months in remission, doing well, we routinely are moving the AZA-VEN every 6 weeks, every 7 weeks, but we prefer to continue both at an attenuated dose, 5 to 7 days AZA, 7 or 8 days VEN, whatever it may be for that patient as you're slowly coming down, and do it every 6 to 7 weeks. We have patients, as of others and published, that if you stop AZA-VEN, there is a risk of relapse within the next 1 to 2 years, favorable mutational group. So in the absence of ultra high sensitive molecular PCR, maybe we'll get that in the next few years, we assume that there is some low level minimal residual disease, do chronic HMA-VEN every 6 to 8 weeks with low dose, which most patients are usually comfortable with. They're coming for labs every 2, 3 weeks once, and they're coming for therapy every 6 to 8 weeks. So the question here from Dr. Gonzalez is, how long AZA-VEN? I think that's the same. We are thinking of it right now as chronic therapy. Maybe in the future, as more data comes out, we'll be able to select patients who achieve high molecular clearance, less than 10⁻⁵, and maybe stop. But for today, our goal is continue it. Yes, we can increase duration, give patients break, reduce the amount of HMA-VEN, but we really just try to keep going. 5 years out, who are continuing it, come to see us, get 5 to 7 days of therapy, and then just come back for labs 7, 8 weeks later. Late stage, one could do that. Should we choose between CPX and AZA-VEN in AML patients who are not candidates for intensive care with morphological signs of dysplasia, focusing on the nature of mutations? Answer is yes, I guess to some extent, but I mean, I will tell you now with all the data coming out, whether it's 3+7 HMA-VEN or last year's ASH 2021, there were 3 different real world analysis, one from France, one from Penn Group, coalition of groups, Moffitt, Cornell, others, that showed that CPX and HMA-VEN had very similar outcomes. What really drove the survival was transplant, no transplant. So when you equalized the transplant rates, or when you selected populations with similar propensity or frequency of being able to get to transplant, CPX-HMA-VEN looks similar. So to me, that is more supportive than of considering HMA-VEN in certain patient populations, because if you're going to go to transplant, it's easier to do it with HMA-VEN than CPX. CPX is still intensive chemo. It's not as severe as anthracycline cytarabine, but it's still intensive chemo. But there is also insurance and other things. CPX does have a frontline label, so that could be one of the possibilities to try to consider it. And I know many people who are comfortable and have used CPX quite a bit find it to be very well tolerated. So some of this will go to your practice pattern experience, but I don't think that we're ever going to see a randomized study of CPX HMA-VEN. And if we do, I think they're going to be equivalent. So that's kind of where we're at. How often do you observe clonal evolution on venetoclax therapy? I don't know if I have an exact number, but we see it. We see FLT3 in about 10% or 15% of patients who relapse post HMA-VEN. We see TP53 in a smaller, maybe about 10% of patients at relapse, whether it's relapse post HMA-VEN or post-intensive chemo. Actually, we published on that. Dr. Short from our group showed that there were emergent TP53 mutations at relapse in about 15% of AML patients, so whether it was post-intensive chemo, HMA, HMA-VEN. So we see it. The important ones, of course, to check for are FLT3, IDH1, IDH2, and maybe today MLL rearrangement, NPM1, because these are the 5 potentially effectively targetable groups, whether it's on trial or approved. So I would definitely check for that at the relapse to make sure you're not missing a new or expanded emergent mutation. So what is your opinion on the use of etoposide 3+7? I don't have a strong opinion. We have not used it. As I mentioned, we like the flag Ida-Clea, and our data with that regimen has been encouraging to us, whether it's with VEN, of course, that looks very good, but even before that, without VEN. So we have not used etoposide. I don't have a strong recommendation. If a fit core binding factor AML has a FLT3 ITD, would you go on a FLT3 inhibitor intensive chemo? Okay, so this one, I would not go. I would do gemtuzumab. This actually, there is data that patients who have core binding factor, at least with our flag gemtuzumab approach, the gemtuzumab is the most important thing. Whether they have a FLT3 or not, whether they had an IDH or not, did not impact their outcome. So patients with core binding factor with FLT3, patients with core binding factor without FLT3, who got a gemtuzumab containing induction regimen, the survival was the same. On the other hand, if you don't get gemtuzumab, the survival is worse. So we are routinely just going with gem. In fact, just today morning, we had an exact patient like this, core binding factor FLT3, because as you know, FLT3 is common. 40% of core binding can have it. And we go with the flag gemtuzumab. If you want to look at the data published by Dr. Borthaker from our group 4 or 5 months ago in AJH. And similarly with 3+7 gemtuzumab, those who had a FLT3 also tended to do very, very well. That's kind of what we would do. Now, there is a study ongoing in Germany looking at 3+7 midostaurin gemtuzumab. I think Christoph Rohlig is the PI for that one, and that one will give us information. I'm worried about cumulative myelosuppression, but let us see. Maybe that could be a potential option. But for now, in core binding, GEO is the key drug, more important than a FLT3 inhibitor. And then lastly, in a patient with a NPM1 AML and CR after induction by flow, first cycle of consolidation, PCR NPM1 is 0.018. After second cycle of consolidation, total third cycle of chemo, it is negative. Do you think chemotherapy is enough and no transplant? I would say if the patient is isolated NPM1 and achieved on a high sensitivity assay, 10 raised to -5 or higher sensitivity clearance by the end of the second or even third cycle, I would be reasonably okay to continue, maybe do 3 or 4 total consolidations and then put them on maintenance with either CC486 or with CC486 plus, then if you have a trial that can allow that. The key thing is, though, isolated NPM1. If this patient had a FLT3, if this patient had a DNMT3A, if this patient had any other adverse features, molecular or cytogenetic, then I would go for transplant. But if it's isolated NPM1, achieving clearance after second or third cycle, you have a high sensitivity assay, I think I would be okay to complete consolidation, do maintenance with close monitoring, and avoid pushing to transplant in the frontline setting. So we're at time. I'm sure you all have clinic, and other things. And thank you all so much for joining. Hope to see some of you again online or even better in person. And take care. Have a good day. Bye.